So, welcome everyone. My name is Chris. I'm one of the Pulmonary Critical Care Fellows here at the University of Louisville, and I'll be talking to you guys about intramechanical ventilation. This is a near and dear topic to my heart, as the ICU is one of my favorite places. And this is something that I think intimidates a lot of people. But what we're going to do is we're going to break it down into something you already know, respiratory physiology, and then we'll take it from there into the basics of when we're starting mechanical ventilation, guiding you through the process of providing supportive care, troubleshooting, and then we'll wean the patient off the ventilator as well. And we'll also teach it from a functional perspective as far as what you guys are expected to know as far as orders and just daily maintenance and routines. So that way you aren't just getting a purely academic lecture. It can be somewhat functional for you as well. Sorry about that. So to begin, we'll start with something that you all know about, respiratory physiology. So the drive to breathe is predominantly produced by carbon dioxide. When you're underwater in a pool, your desire for air is not from a lack of oxygen. It's from an accumulation of carbon dioxide. So that triggers in the brainstem, and that triggers the phrenic nerve to fire, resulting in the diaphragm contracting and flattening and improving and increasing intrathoracic space and volume. And so that increase in volume drives a pressure difference between the atmosphere and your lungs. And so that's how you passively get air. And so what does the lung try to achieve at baseline? Well, it tries to achieve two things, oxygenation and ventilation. And please note here that I've highlighted oxygenation in red and ventilation in blue, which we're defining here as the exchange of carbon dioxide. This will be a persistent theme throughout our lecture to help get you guys acquainted. And the other concept you want to be aware of is the one of compliance. So your lungs have a set compliance at any given point in time. And so when you change a volume, the pressure will change as well. And we'll reiterate that concept later down the line. For the ABG, we routinely report as pH with a PCO2. And so those two numbers represent your ventilation for that point in time. And then we'll also talk about PO2 on FiO2 with PEEP. So there's a lot of letters and a lot of jargon there. So just to give you guys an example for a normal human being such as yourselves, you would have a pH of 7.40 with a PCO2 of 40, a PO2 of 100 on 21% FiO2 and 0 PEEP. So to begin with a pathophysiology, let's first talk about hypoxemic respiratory failure. And so when we think about hypoxemic respiratory failure, we should think about it in terms of 5 causes. Here I have the alveolar gas equation, which really you can just kind of mentally discard. But what the key points here is that hypoxemia is usually defined as a PO2 of less than 55 on an ABG. And so that correlates here to about an SPO, to 90% on your hemoglobin oxygen dissociation curve. So, and you remember your baseline's about 100. So we're really just saying that you can survive without very much oxygen at all. But it doesn't really represent that well on pulse ox. We also define refractory hypoxemia as a low PO2 while you're on positive end expiratory pressure to help splint open the alveoli. But as far as the causes of hypoxemic respiratory failure are concerned, you have 5 when you can divide it into 2 classes. A normal AA gradient, where there's no disruption in your alveolar capillary interface, or there's a disruption in your alveolar capillary interface, and so that means you have more oxygen in your alveolus than you have in your capillary. And so alveolar hypoventilation is one of the classics. This is, and you oftentimes in this day and age, you'll see it from the setting of opiate overdose, where the patient no longer breathes, no longer has that respiratory stimulus. And so you'll see a low PO2 and a very high PCO2, and you can diagnose it that way. It will correct with oxygen supplementation. Decreased oxygen tension is the other common cause. And so your pulmonology attending's favorite question will be, what is your FiO2 on sea level? That's 21%. The trick question here is, what is your FiO2 at Mount Everest? And it's still 21%. What changes is the atmospheric pressure at that altitude. And so the PO2, the partial pressure of oxygen is decreased that high up. And so you can't get as much oxygen as a result. And that's why you need supplemental oxygen there. Poison gas, so if you're not getting enough oxygen and there's a gas that is or oxygen depleted, then that's also another problem. But ignoring the normal A gradient causes, for a second, let's talk about the elevated AA gradient. And the most common cause of hypoxemic respiratory failure is the classification of VQ mismatch. This is what you'll see most often in pretty much the hospital setting. So that's pneumonia, COPD. It's essentially where parts of your lung no longer ventilate, but still get blood, and the reverse happens as well. So it's more of a macro picture. This does respond to supplemental oxygen. Now, if you have a pure shunt, that means that your alveoli are all filled up and cannot transmit oxygen into the capillary system. And so oxygen will not correct this. It's very rare to have a pure shunt because effectively that patient is not resuscitatable. And then finally, even more rare cause is decreased diffusion. And so this is scarring along the interstitium, the black line here. And so that increase in thickness and scar tissue does not allow for oxygen to transport from the alveolus into the capillary. So when you really think about it, how can you use this on a day-to-day? Well, if your initial differential doesn't work for hypoxemic respiratory failure, you can go back to get an ABG, a chest x-ray, and ask yourself, well, what am I missing here? Am I looking for a VQ mismatch? And should I give oxygen and supplement it as much as I can? Is it a shunt? And no matter how much oxygen I give, the patient's not improving. Or just lung scarring as a result of decreased diffusion. And you can from there have a broader differential and work your way down to identify what the cause is. The other thing you want to think about is hypercapnic respiratory failure, so elevated PCO2. And so while we don't expect you to memorize equations here, this is a very handy thing to know. So there are three causes of elevated partial pressure of carbon dioxide. The first is that you made a bunch of it. Second is that your minute ventilation goes down, or that your dead space ventilation goes up. And so decreased minute ventilation is one of the classics here. And so minute ventilation is we define as tidal volume times the respiratory rate. And so that's going to be super important as a concept for the ventilator down the line. So hang on to that for a second. As far as causes of decreased ventilation, you can think about it in terms of four concepts. Is the patient breathing? Is it because they can't breathe from obstruction from COPD or an asthma exacerbation? Are they not able to breathe because their brainstem function is depressed from opiates, benzos, endocrine pathologies, things like that? Are their lungs very stiff, and so they're not able to mobilize using their baseline muscles to breathe better? And so that would be things like pulmonary edema, ARDS, pneumonia, so things that have made their lungs stiffer or the pleura stiffer, so pleural effusions. Muscle weakness is the other thing that we oftentimes kind of forget about since it's not directly related to the lungs. Increased dead space, that's oftentimes COPD, giving too much PEEP on the ventilator, or increased CO2 production. If you're on patients on tube feeds and you're giving them tons of carbs, that's another cause for CO2 production. So now that you have an idea of respiratory failure and in terms of the ways that you can classify them and then develop your differential, well, what about intubation? If the patient's not doing well on oxygen, you've tried the standard nasal cannula, oximizer, face mask, high flow nasal cannula, then you want to consider a few questions. The takeaway from this slide right here effectively is that there is no specific guideline for when to intubate. It's a clinical judgment. So that's why this slide is not very specific. Are they not able to protect their airway at all and they're mentally out and they're not breathing? Then proceed to intubation. That's pretty obvious, but pretty extreme. Well, if they're still awake but they're not doing so well, the questions you have to ask yourself, is the severity of their disease high enough? And do you think it's a reversible cause? If so, then you can potentially bypass them with a face mask. Or if you don't think you can reverse it, then you want to proceed with intubation. As far as things for interns and residents to know, once you've decided to commit to the intubation, the key here is that once you've intervened, you need to have a plan to how to identify if your intervention worked. And so with an intubation, what do you want to know? You want to know if it's the ET tube's in the right position. What is that right position? Well, it's 3 to 4 centimeters above the carina. So typically 3 or 4 rib spaces above. So the other thing you want to know is that most chest x-rays are not this clean. You'll have a lot of lines, gowns, buttons, nipple rings, whatever have you, clouding the picture of the chest x-ray. And so you'll see what's called a radiopaque stripe. There's a strip of metal that goes down the entire length of the ET tube, and that stripe helps identify that this is the ET tube itself, in addition to the outline of the ET tube when caught on FOSS. This is a really handy slide to give to all my residents when I'm on the unit as far as adequate positions and incorrect positioning. So this is something I can hand to you guys if you'd like, but this is a good starting point. And then just let me know and I'll get this out to Sam. So congratulations. The patient's been intubated. You know, again, we've talked about you intervened. Now you need to make sure that your intervention has been satisfactory. So what should you know when the fellow or the resident has intubated the patient? You should order a stat chest x-ray for the indication of intubation. You should discuss the initial parameters with the intubator. And you should also obtain an ABG within 30 to 60 minutes because you want to see are your vent settings appropriate for the patient? And is that patient stable from a respiratory standpoint? Is their ventilation adequate? Is their oxygenation adequate? So those are the three things that need to be done immediately. What about other orders that you need to know? Because so often we just kind of disperse from the room and things are expected to get done. Well, sedation and analgesics are really important. There's now a plastic tube in someone's trachea that should not exist there. And so the patient will wake up from the rapid sequence intubation medications. And so your next goal is to make sure they're comfortable and compliant with the vent. So those medications include propofol and fentanyl here in the medical ICU. The other thing you want to know is that you want to have restraint orders, specifically bilateral wrist restraints for most patients. Now, one of the most frustrating things about being an intern is having to order this every day. Why do we have to do that? It's because it's a Center for Medicare and Medicaid Services requirement. And unfortunately, as a resident, we are mostly paid through CMS, so can't afford that kind of hit. As far as a Foley order, you know, the patient's strapped to a bed with an ET tube in their face. They're not really moving, and they should be able to pee, and we want to monitor for urine output, especially if they're truly critically ill. For the most part, patients should get DVT prophylaxis and GI prophylaxis. And to administer oral medications, you want to make sure that you have either an OG tube or an NG tube. Oftentimes, if you're concerned about the patient having a GI bleed, you might want an OG tube to make sure that you can suction out the blood, or if you need to suction out aspirate in general. Starting tube feeds early is one of the Aspen guidelines and something that should be considered. The other thing, too, is our respiratory care orders. While this is not something we think about routinely, these are best practices endorsed by the Society of Critical Care Medicine to reduce your risk of ventilator-associated pneumonias. And ventilator-associated pneumonias have a high mortality and morbidity and a longer length of stay in the ICU. So what are those orders? Make sure the patient has a head of bed to 30 degrees on an incline. Make sure the patient gets routine suctioning. Make sure the patient gets humidified, moisturized air. And make sure they get oral care. Again, reiterating vent orders, make sure that when they're adjusted that the order is in. And then the other thing we want to do is make sure that they have daily sedation vacation orders. Make sure that their mental status improves and that they do not accumulate too much of the sedative so that they're impossible to remove from the vent at the earliest opportunity. I have not really highlighted the selective oral or early mobility because those aren't things that we routinely do here, but those are things that other institutions will do. So I've told you a lot about what to do, but what about daily x-rays and daily ABGs? They're not routinely indicated, is the long story of it. Now, you will notice this little disclaimer here is that it depends on your attending as well. So if the attending wants it, or just better off just getting it. And what should you know when you're rounding on a ventilated patient? Well, check with the overnight team to make sure that there's no crazy event that happened overnight, like the patient desaturated and is on tons more support. Discuss with the RT if there's any changes from their perspective, specifically secretions. Check with the RN. How are they doing with sedation? Are they up, down? Are they the same? Are they neurologically responsive? And then over time, as you get a feel for this, then you can start suggesting, well, you know, the patient's stable, they're improved on the vent. Can we try a spontaneous breathing trial? And you'll get there. And so cornerstone of the ICU is supportive care. So what does supportive care on the vent mean? It means making sure the patient's oxygenated, but not too much, making sure their ventilation is appropriate, so making sure their acid-base status is normal, because our biggest buffer in our body is bicarb. And so CO2 is part of that equation. Patient comfort is also incredibly important to improve synchrony and reduce injury on the vent. So checking a clinical pain scale such as the CPOT and checking the RASS score every day is important. And then finally, we want to make sure that our intervention isn't causing harm. And so you want to make sure those settings that we have on the patient on the vent are appropriate to reduce the ventilator-associated lung injury. So this slide is really just a summary of all the modes that are routinely used, but that is not for you guys to really know right now. We're going to break it down a little bit further. So we'll start with the classic. The classic here is called volume control. It's also called volume cycle assist control. And so what does assist and control mean? Control means that the vent has provided the breath. And assist means that every time the patient breathes on their own, the ventilator will also deliver that breath to them. So volume control then means that every time the patient breathes or the vent is timed to give the patient a breath, the patient will get a set volume. So if you set for 450, the minimum the patient will ever get of any breath is 450 milliliters. What are the pros of this? Well, it's the easiest mode to kind of use. It ensures adequate minute ventilation because we just said the machine gives a specific breath rate. You set that. We also said that you deliver a set volume, and we said minute ventilation is the multiplication of those two things. So you ensure minute ventilation, which is good for the critically ill. And we can also set lung protective ventilation. What are the cons of this mode? Well, this is a little bit beyond the scope for interns and residents, but the flow rate is fixed, and so it's actually somewhat uncomfortable because you kind of breathe on a plateau, but it just shoots up and then you stop, and it's very disconcerting for most patients. The other con is that if you don't monitor your pressures, you can induce barotrauma or pressure-related injury. So here we talk about independent variables. And again, remembering the blue and the red. Blue signifies components relating to ventilation. So respiratory rate and tidal volume are associated with your ventilation and clearance of your PCO2. Don't worry about the flow rate. PEEP and FiO2, fraction of inspired oxygen, are your oxygenation settings. So what are a classic setting you should start on for most patients in the ICU? Well, this is kind of a banner of what you'll see. So you'll set them on AC. You'll set them on 6 cc's per kilogram of ideal body weight, and that's a calculation based on height. Flow rate, just set at 70, or let your RT take care of that. Respiratory rate. Classically, the textbooks say 25% of the patient's pre-intubation respiratory rate, but if you just want to be like me and the rest of the fellows I polled, just set it at 16. What about your PEEP? Just if, for the most part, 5 will suffice. If they're extra large, their BMI is very high, choose 8. And then always start at 100% FiO2 because when you go from negative pressure ventilation to positive pressure ventilation, there's a transient period of VQ mismatch, and you don't want the patient to hypooxygenate. What we measure here are pressures, so peak pressure and plateau pressure. And then here is a graphic that I made for you guys to kind of show you what a vent looks like on the screen. So again, we have our settings, so AC, VC, so volume control. We set our rate here on the bottom. So you set the rate of 24, you set the rate of 500, the flow, O2, and the PEEP. The top banner or the sides on here, depending on the machine, are what the vent senses. So here you'll notice that you'll see a peak pressure of 31. And so that's the sum of the resistance and the stiffness of the lungs and the stiffness of the chest wall. Why is that important? Because you have certain limits to pressures before you start having an increased risk of causing ARDS related to the vent. Mean pressure, really don't worry about. PEEP is what the machine is sensing as the baseline PEEP, and this can fluctuate a little bit. I to E stands for inspiratory to expiratory ratio. It's really kind of outside the scope of what you need to know. F total is respiratory rate, and F stands for frequency. So this is what the patient breathes. And so if the patient's not well sedated or still awake, they can breathe above the rate of the vent. So they can, if you set a rate of 24 and the patient's breathing 30 and you see an ABG that looks really bad, setting them to a 28 won't change anything because the patient still is breathing 30. And then you have your exhale tidal volume here. So what an exhale tidal volume senses is the volume that's given back to the machine. Ideally, you want to see that the tidal volume you give and the tidal volume returned are the same, because you want to lend them the air and get it back eventually. Otherwise, they trap air, they get barotrauma and more ARDS. The V dot here is the minute ventilation that's sensed by the vent. So if you take 0.5 liters times 24, that's 12. So the next mode that we'll talk about is pressure control. And so this ensures a set pressure every time a breath is delivered. So in general, that pressure is about 15 to 20 depending on the patient. It is a general purpose mode. It does limit the amount of pressure the patient will get, and so that can reduce barotrauma, but it does not limit the amount of volume that they get because it changes with compliance, as we talked about. Why would I choose this mode? Well, for patients who are awake and who are having difficulty with volume control because of air hunger, I'll choose this one because the patient can dictate the flow rate, and that can alleviate a lot of need for sedation. What are the cons of this? Well, because we set pressure and because compliance can vary depending on how sick the patient's lungs are, you don't always guarantee an effective minute ventilation. And so if the patient gets stiffer lungs or more pulmonary edema, more ARDS, pneumonia, over time their minute ventilation can drop and they develop this very severe respiratory acidosis. The other thing too is that if you overpressurize, if you give them a lot of pressure and they start getting better, you can give too much volume and create volutrauma, which essentially is ventilator-associated ARDS. We talked about the independent variables here again, respiratory rate, the inspiratory pressure, again, 15 to 20. So this is what you're going to deliver with every breath. And the I time is the inspiratory time. So that's the period of time which you deliver that pressure. Most of the time you'll shoot about for 0.9 comfort. Don't worry about the rise time. It's just there as a setting for the fellows, attendings, and the RTs. And again, we have our PEEP. So I hope that you're sensing a theme here about what we're trying to achieve. There are modes that control ventilation and modes that control oxygenation. And then you can interpret the adequacy of these settings based on your ABGs. So here's an example again. So we have our inspiratory pressure, I time. This signifies that this is a pressure control setting. And this green C here is classic to the vents we use at U of L. This means that the patient is in a control mode and that breaths are being delivered. And I'll explain why that's important in a second. And that second has come. So this mode, pressure support, is our standard weaning mode. So this is classically, there is no set rate. You will have a backup rate on the vents we have here in the ICU, but this means the patient has to breathe on their own. They have to develop their own minute ventilation, their own respiratory rate, and their own tidal volume. This is the most comfortable mode, to be honest with you, because the patient can determine the flow rate, the air, and everything. Sorry, that is incorrect. This is not a lung protective ventilation mode. I apologize, but it is most comfortable. As far as independent variables, something you should know is that the pressure mode that you would supply is interpreted as 10 above PEEP, or pressure support above PEEP. So whereas pressure control is 15, the flat 15 over 5, if you say you're in pressure support setting of 8 with a PEEP of 5, you're really delivering an inspiratory pressure of 13. And that's unique to the weaning mode, just by nomenclature and convention. Okay? Again, the tidal volume varies based on compliance, and we'll talk about what effective weaning modes are, or what effective weaning variables are. Here is a graph. You'll see the pressure. You'll see the O2 and the PEEP. Here's a red S, and that stands for spontaneous. So the patient is breathing on their own, and so if the patient is not very strong and you leave them on it, they will stop ventilating eventually. And it's just going to end in a disaster, everyone. So now that we talked briefly about the three major ventilatory modes, well, what are you supposed to do with a patient on the vent? The ventilator, philosophically, is a support device. And so it doesn't really treat anything. It just gives you time to perform the underlying treatments. So here we have respiratory care, sedation, analgesia, identifying the target disease, and reducing your risk of adverse events related to being on the vent. So we talked about the different classifications of respiratory failure, hypoxic, hypercarbic. Working down your algorithms, you can identify what you need to do to achieve improvement in ventilation and oxygenation. So say, for instance, the patient has a pneumonia that's very severe. You would give them antibiotics and give them time to heal, to rest on the vent. A pearl that you should know is that vancomycin don't treat everything. Not everything includes atypicals. So if you're going to intubate someone for pneumonia while you're empirically and while you're working them up, don't forget to add IV azithromycin. If you're concerned about bronchospasm, so a very severe asthma or COPD exacerbation, give nebulized bronchodilators. And you can do this routinely on the ventilator too, because having an irritating tube can induce bronchospasm. So you can give albuterol or albuterol and ipratropium. If the patient received tons of fluid for sepsis and later developed volume overload and pulmonary edema, you can start the deresuscitation process with diuretics. We talked about VAP management with endotracheal suctioning. And another pearl to know is that mucus plugging is the most common cause of elevated peak pressure alarms because you've increased the resistance by narrowing the tube effectively. What should you be targeting for oxygenation? Based on the ARDSNet protocol here, we target a PO2 of 55 to 80, and that corresponds to about 88 to 95%. So you don't ever really want to oxygenate patients too much, and we'll talk about that in the next slide. Our target FiO2 is less than 60% within 5 days of mechanical ventilation. And again, we'll talk about the risk of oxygen toxicity in the next slide. Our goal parameters for oxygenation, a pH of 7.30 to 7.45 is our general target. Now, if you're performing lung protective ventilation, that means you're shooting for low tidal volume ventilations. And so if you're low tidal volumes, you have a low minute ventilation. We then allow for what's called permissive hypercapnia, where your pH can be 7.25 to 7.35. Where should you not do this? The patient has elevated intracranial pressure, so like head trauma. And finally, we talked about the VAP bundle. Again, it keeps popping up because it's incredibly important to make sure these orders get in so that we can reduce the risk of adverse complications while on the ventilator. So I mentioned a lot about the vent being a support device, and it does come with inherent harms to it if you're not familiar with how to use it effectively. So if you overdistend the lungs with excess pressure, you can cause alveolar rupture, and that rupture leads to a cytokine cascade leading to more alveolar injury, or ARDS. The lung diseases specific to barotrauma are asthma, COPD, and ARDS because of the compliance issues related to them. To reduce your risk of that lung injury, you target plateau pressures less than 30, and we'll talk about how to generate a plateau pressure. Peak pressures, you generally want to shoot for less than 35. The next issue is if you're on a pressure mode, you give too much volume, or if you decide, hey, I'm just going to give a ton of volume to this patient, breathe, you can overdistend the lungs, again, cause rupture and inflammation, and more ARDS. So generally on the vent, your safe bet is to target 6 cc's per kilogram of ideal body weight. We said, again, the vent is a support device, so the patients can breathe larger tidal volumes if they need to, or they feel like they're not well sedated. That's okay to an extent. In general, we accept a range of 4 to 8 cc's per kg of ideal body weight. And there's a nice calculator on MD Calc can help calculate that for you. Atellect trauma is probably the most dangerous, but unfortunately, there's really no way to kind of know what the safe limits are. So if you have constant shearing forces from the alveoli collapsing and opening repeatedly, that leads to more ARDS and injury. So we need to make sure we have adequate PEEP for recruitment. And so that's the reason why we stay at a minimum of 5. The driving pressure is defined as plateau pressures minus PEEP. That's more of a pulmonary critical care thing we can talk about later, but it's just to tell you that these are things that we do monitor in the ICU. Oxygen toxicity can cause free radical formation, and that's why we target an FiO2 of less than 60. But if the patient is hypoxic, we don't sacrifice their oxygenation to achieve an FiO2 of less than 60. We accept that because the risk of death from deoxygenation is so much higher than lung injury down the line. And here's the ideal body weight calculation. Notice that it's based on height, and there are different, it's based on gender as well. So this is really not for you guys to like learn right away. This is a table that I generated for you guys from Up to Date regarding the different sedatives and analgesics that we use in the ICU. So, long story short, start with propofol, start with fentanyl. Here are the ranges for the drips. Here are the things you should consider. And for those of us in the ED, ketamine is something that the ED uses quite a bit, but we don't use as much here in the medical ICU. And if you do choose to use it with the fellow's guidance, then you should know that you have to manually change the orders every time you want it titrated. As far as troubleshooting the vents is concerned, really there are 3 things to think about. Talk to your RT, look at the ventilator alarms, and make sure the patient's ABCs are being addressed. The ABCs being outside the scope of the talk right now. So what does your RT do for you? They help manage the vents. They also can get ABGs. They can also help modify the ventilator settings to help target a specific disease course. So the more comfortable you get making diagnoses, generating a plan, the more you can engage your team members to help maximize the patient's outcomes. And what else? And so as far as interventions that the RT can perform, they routinely perform suctioning. They routinely administer bronchodilators. Pulmonary vasodilators are things that you should talk to your fellow about. They assist with prone positioning. And finally, while we don't do it here at U of L or the VA, they do assist with managing ECMO. As far as alarms are concerned, this is more of a fellow level thing. But what should you know as becoming interns and senior residents? Always think about your ABCs, airway, breathing, circulation. Is the patient stable at that point in time? If so, you have time to think. If not, begin resuscitation. And then from there, once you stabilize them, make sure that the patients have been checked out, the patient's ET2 has been checked out, and the ventilator has been checked out. So coming back to the physiology, we talked about hypoxemia and hypercarbia. So what are your limits? So if you're in trouble and the patient's desaturating, what can you do about that? Well, in the immediate interim, you can increase the FiO2 to 100%. So give them pure oxygen. If the patient is not on a lot of PEEP, you can increase it maximally to a PEEP of 20. But, if you're going to need to go above, let your fellow know and discuss the plan with them. What about your upper limits for managing a respiratory acidosis or a metabolic acidosis, and you want to try and compensate for that? You can increase the respiratory rate, so about 30. Just make sure you let someone know. You can also increase the tidal volume to about 8 cc's per kg of ideal body weight. Going above, you really need to consider hemodynamics and lung injury, so again, talk to your fellow. As far as the hypercarbia is concerned, make sure you address the underlying etiology. Most commonly with COPD, you're going to see it with COPD, it's going to be steroids and bronchodilators and antibiotics. We talked a little bit about peak pressures and plateau pressures on the vent. So what is a peak pressure? The sum of all the airway pressures. So you have your PEEP, and then all of a sudden you have all the airway pressures from their resistance of the large airways, the medium airways, stiffness of the lung, so the compliance, the chest wall compliance. And so that should generally be, for most people, less than 35. And we target that because at that 35 threshold, that's when you start incurring lung injury. The plateau pressure is a little different. Plateau pressure is when we have zero airway resistance So zero flow, we just get the lung stiffness and the chest wall compliance. And so essentially it's how stiff are the lungs and how much can you stretch them before they snap. That limit, based on the ARDS-NET protocol, is less than 30. How do you get that number? Sorry about that. There's a button on the vent called inspiratory pause, INSP pause, and if you hold that, especially on volume control, for about half a second to 1 second, you will see in the upper right-hand corner a number of ppl generate. That's your plateau pressure. And that's how you gauge whether or not your therapies and your ventilator settings are appropriate. So what does that mean for you, though? So these are just numbers to you right now. So if you have a high peak pressure, so above 35, but your plateau pressures are normal, so below 30, what should you think about? Well, you should think about endotracheal tube blockage, specifically mucus plugging and secretion. So have the patient either suction the patient or call someone to help suction the patient for you. Is the patient not well sedated and do they not have a bite block in place? Sedate them. Is the ET tube kinked? You should unkink the tube. So basically it's what are causes of increased airway resistance when you have a high peak pressure normal plateau. The other cause would be for the patient, a bronchospasm. So give them a neb. And then the other causes, not specific, are really the patient. Is the patient coughing a lot while in the ET tube? Is the ET tube touching the carina? Are they having ventilator synchrony? At that point, you should contact your fellow. Is the patient just really fat, or is their spine really topsy-turvy and it's affecting their lung volumes? If so, those are things that you really can't manage, but still talk to your fellow. If you have a high plateau pressures and high peak, so plateaus above 30 and high peaks, you should think about lung stiffness. And so we talked about that as shunting and VQ mismatch, right? So these are the causes. So if you suspect pulmonary edema, so you see a lot of fluffy alveolar infiltrates, it's okay to give them diuretics. If you see a complete whiteout of the lung with mediastinal shift to the side of the whiteout, you should think really aggressive mucus plugging, and you should call the fellow to assess for bronchoscopy. If you see a consolidation, continue antibiotics, and just give them time. ARDS is lung protective ventilation. Did you right main stem? And so effectively, are you putting 2 lung volumes worth of air in 1 lung? You get a chest x-ray and retract the ET tube. Or is the thoracic cavity really small now because of the giant tension pneumothorax? Well, call the fellow to have a chest tube put in. The more concerning thing to me actually is the low pressure alarms, because that means that the patient is not getting any form of minute ventilation. And so the most common thing that I see is the tube is disconnected, and you'll hear a hissing sound periodically as the vent tries to ventilate the surrounding atmosphere. So if it's disconnected and you are somewhat confident in how to put it back together, just plug it back in. Otherwise, call someone. Is the patient not getting enough flow? Talk to your RT or fellow. Has that ET tube been in there for a while, and has the RT been struggling with a cuff leak or cuff rupture? They've notified you. Well, call the fellow to assess that and see if you need to have a tube exchange, because those are some of the highest risk procedures that we do here in the ICU. And this should go without saying, but if the patient's self-extubated, call the fellow and consider emergent rapid sequence intubation. Because when the patient self-extubates, they have that pilot balloon up. That kind of just irritates the tracheal lining, bursts through the vocal cords, causes swelling and edema. So that is a very difficult airway. So now that we've talked about troubleshooting, how to maintain someone on the vent, let's talk about weaning. So how do you assess a patient for weaning readiness? Did you first fix the underlying cause for why they're intubated in the first place? If they're not making improvements as you would expect within the 48 hours, my rule is to make sure I'm not missing another differential diagnosis. So once the patient's better, they're improving in terms of oxygenation, their metabolics are under control, make sure that you stop all sedation in the morning. There's a habit at U of L where we wean down sedation. That's not a thing. You just turn it off with the nurse, and then wait 30 minutes and then proceed to a spontaneous breathing trial. spontaneous breathing trial's duration should be at 30 to 60 minutes because there was a trial recently that showed more lengthy SBTs had an increased risk of death and failure. Also, make sure you involve your attending or your fellow to make sure that it is indeed the right time to extubate the patient. Well, that's all well and good to talk about from a very high level perspective, but what are things that you should be looking for? Those things are, is the patient neurologically arousable on their spontaneous breathing trial? Can they give you a thumbs up? Can they raise their head? Can they cough for you? Is their heart rate under control? Are they on low dose pressors or ideally no pressors? Are they not having an ischemic event? The other thing you want to know is the patient oxygenating well on minimal vent, which is considered 40% FiO2 and 5 of PEEP? 8 again, if you're a very large patient. Is there CO2 at the patient's baseline? Or is their pH normal? The PCO2 does not need to be 40 for patients who retain CO2 all the time. That would probably lead them to being reintubated very soon. Other things that are less firm is the patient afebrile. So have you addressed the underlying causes? Is the patients like hyperkalemia, hypocalcemia, things have been addressed. So now that you've determined that, yes, the patient's ready for an SBT and you have them on the SBT, what should you be looking for? So the first and most important thing is their oxygen good? So are they on 40% FiO2, 5 of PEEP, and are they oxygenating well? Keep in mind that the average adult has a P to F ratio of over 400. We're just asking them to beat half of that at 200. And so that odds ratio of success to extubation is 200 compared to patients who do not have this. And so this is the most important factor for extubation in my mind. The other thing you want to know is, are they ventilating well? And how do you determine that on an SBT? There's this concept called a rapid shallow breathing index. And that's your respiratory rate divided by your tidal volume in liters. And the average person has an RSBI of about 50 per minute per liter. We're just asking for them to be better than double that. And so basically, if you think about what an RSBI means, it means, are you breathing like you guys right now at rest or asleep? This lecture. So if you're breathing at 12 breaths a minute with a tidal volume of 500, that's an RSBI of 24. We're asking them to breathe a little bit better than 4 times that. So we really are giving them quite a bit of leg room to get off the vent. And that odds ratio is 10. The other thing you want to consider is a negative inspiratory force appropriate. So generally we shoot for negative 20 to negative 25. Other things, are they making appropriate tidal volume? So sometimes when you ask the respiratory therapist for respiratory vitals, you're going to get a list of stuff. And so what I want you guys to focus on are the weaning thresholds here. But I'm giving you guys a reference so that way you understand what we're trying to achieve. And that's really not super normal. Just good enough. And so you're going to get the RSBI, the NIF, tidal volume, vital capacity. So ideally you would have greater than 10 mils per kg. Again, that's 1/6 of what the average person would be. So we're not expecting tons of great effort on the vent to get them off. Okay. So they pass all those things. You successfully liberated the patient from the vent. What are you going to choose for oxygen supplementation once you change them from positive pressure to negative pressure? Because again, we said earlier that a change in a positive pressure or negative pressure induces a VQ mismatch. So if the patient's otherwise doing well, they're young, they're healthy, a nasal cannula would be okay. If they're a patient with CHF and really bad systolic heart failure, or they're a COPD, consider BiPAP. And so it depends based on what your understanding of that patient's normal physiology is. What you should add in is extubation, one-time order for respiratory therapy in order to help them extubate on time. And then check back on the patient in 2 hours just to make sure that they're doing all right. And then depending on the attending, you can determine time of transfer. So to summarize, we have a checklist here. So first of all, you need to assess, does the patient need to be intubated? Did you check that your intervention, your intubation was successful? Is your ventilator setting successful? And then how are you going to continue supporting this patient through their process and trying to get them off the vent? And then you assess this on a daily basis or 2-hour basis, depending on how sick the patient is. Finally, as far as ventilator liberation is concerned, remember that oxygenation is the key here. If they're not oxygenating well, please do not consider extubating them. Also, is the patient ventilating well on their own? Is the rapid shallow breathing index appropriate for them? And then is their organ failure resolved? Those are the keys to the beginnings of understanding the mechanical ventilator. So I'll open the presentation up to questions.
Thank you. And you guys can feel comfortable to enter questions in the chat window, say them out loud, whatever works best. We can see the chats over here. So one thing I wanted to impart to you guys, it's really an excellent opening lecture from Dr. Chan, is to think about where you might encounter this not only in the hospital, but also in your board exam. Every MixApp or UWorld question I have, and Nadine, we will get that out to you. Anytime you get a board question on this, okay, they are probably going to give you the current vent settings, and they're either going to tell you the patient is not oxygenating well or that the vent is alarming. They want you to recognize that the patient's tidal volume is appropriate for their ideal body weight. If they're alarming, it's usually that it's not appropriate or that there is some mechanical issue. One common answer is look, high peak pressures just disconnects the endotracheal tubulum circuit. So
yeah, exactly.
Yeah. So yeah, be aware of that. Go ahead.
I was going to say, as far as troubleshooting, I apologize. So one thing that about this PowerPoint here, so notice here that with the respiratory rate and tidal volume, so this is an order of what you should be thinking about. Increase the respiratory rate first if you're concerned about a hypercarbic respiratory failure, then tidal volume because of the lung injury and lung protection we're trying to achieve. Similarly, increase the FiO2 first and then the PEEP, and then just make sure the fellow knows so that way we can adjust from there and work with you on an individual basis. Go ahead.
No, excellent. And can I just skip ahead to which is the slide with the PO2 FiO2 ratio towards the end?
The weaning.
Yeah, the weaning. It's just one more teaching point, then we'll let you guys go and kind of get back to rounds here. So I love this slide because if you look here, this is really the bread and butter of understanding vent physiology and this is very true for our coronavirus patients as well. If you have a patient who is requiring a very low FiO2 to maintain their arterial oxygen, that patient's going to have a good ratio because that's what you want. You want a patient who is requiring very little support from the vent to maintain a very high level, which will give you a higher ratio. It's just think about that intuitively because the goal of a vent, if we simplify it, is to give the patient oxygen to get into their blood to participate in metabolic processes. So if you guys can kind of internalize that, and this is as simple as looking at what they're getting on the vent and look at what the blue number on the monitor looks like. If you can kind of internalize that, that's the first couple weeks of NICU right there.
Exactly. Yeah. Yeah. And so the PDAF ratio is important for ARDS, but this is something you can just keep in mind, like as Sam was saying, how much support am I delivering? And a low PDAF ratio in the setting of ARDS actually heralds different levels of mortality depending on how severe they are. But I just wanted to provide you guys this information so that way ICU and ventilators were less scary.
Excellent. Guys, before we let you go here, first of all, thank you for a great crowd the first day of our academic year. Does anyone have any questions? You can put it in the chat. You can text me if you don't want to share it publicly. You're welcome to share into the blue jeans too. You can just unmute your microphone. Any questions? We have one question real quick.
Oh, yeah. Auto PEEP?
Yeah.
So auto PEEP essentially is when other terms for like breath stacking. So essentially the patient isn't able to exhale completely, and so they retain a little bit of volume, and that volume creates pressure in the lungs, so they start building up over time. Often you'll see this with patients who are very dysynchronous, who are very anxious, and so sometimes sedation can be helpful. The second, and probably equally as common, scenario is a COPD exacerbation or asthma exacerbation with obstructive lung disease. And if you see the patient is tanking in terms of their hemodynamics, their blood pressure is just dropping, and their ventilator just doesn't look right at all, the answer in life and in boards is to disconnect them from the ventilator, allow their lungs to just completely settle down, and then plug them back in, focus on sedation, focus on bronchodilators, and try to lower the respiratory rate. The other key to auto PEEP is that if you're seeing early signs of it, is to add that PEEP on the ventilator to match it, so that way they don't keep stacking and keep building up from there. So that way you support every breath they get with that additional PEEP, so that they're inflating and deflating the entire time. So the keys again to auto PEEP: if they're crashing, disconnect them from the vent. If they're early, consider up-titrating the PEEP to match what you're seeing based on that the PEEP sensed. And then finally, if for obstructive lung disease, lower the respiratory rate because you need to increase time for exhalation.
If you guys ever want to personally simulate auto PEEP, just so you can get an idea, there's one, like, you can literally do it right now. Take a full breath. Don't finish exhaling and then start your next breath. So it literally looks like this. Eventually, you feel your lungs start to get really tense and fill up. This happens sometimes when patients are on synchronized intermittent mandatory ventilation, but they're not sedated. And that makes sense, right? Because if they can feel themselves breathing, the vent is giving them a set breath. They're trying to take their own breath, so their lungs build up like a balloon. This can give you a pneumothorax. So be very careful and look at these patients. Simulate it yourself. Feel what it feels like. It's very uncomfortable.
Yeah. Appreciate you guys' time, and I hope the ICU goes well for you guys. You guys got a great fellow in Arjun.